Welcome to the Collective Voice of Health IT, a WEDI podcast.
Hello, and welcome to another episode of the Collective Voice of Health IT, a WEDI podcast. I'm your host, Matthew Albright. My day job is Chief Legislative Affairs Officer for Zelis Payments, Z-E-L-I-S. Zelis's mission is to enable providers to simplify and save on their payments and claims. I also serve as the Communications Committee Chair for WEDI. That's W-E-D-I, which means the Work Group for Electronic Data Interchange. WEDI is a national membership organization where the health information technology community connects, collaborates, and creates solutions for a better health system. Also, in our virtual studio today, we have Eugene Sayan, founder and CEO of Softheon. Softheon is making administrative simplification a reality in the ACA marketplace, in Medicaid managed care, and in many other areas. Eugene, we're very excited to talk to you today. It's an honor to have you on our show.
Thank you, Matt. It's an absolute pleasure of mine to join you. And thank you for the opportunity.
Very good. And we're coming at a very opportune time. It's the beginning of the year. Lots of things have happened this past year. We've got a changing administration. We've got lots of things on its plate. But before we look to the future, I wonder if we can spend a little bit of time where you can tell us a little bit more about yourself. It's always interesting to hear the background stories of healthcare leaders, how they ended up in healthcare. And so often we hear that, sometimes other lessons that they learned earlier in life or in other experiences, they can then apply to healthcare. So maybe tell us a little bit about yourself and where you're coming from and how you ended up in healthcare.
Absolutely. As you pointed, I am the founder, CEO of Softheon. And by the way, CEO stands for Chief Expectation Officer. So it's my job at Softheon to kind of set the expectations and align the expectations and meet those expectations. Basically, Softheon really is a technology company foremost, including myself, a degree in electrical engineering. Later on, pursuing my American dream, I came to the U.S. and changed a little bit of a pivot around computer science, if you will, on my way to a PhD program. Soon I realized that I need to get a better job, or better paying job, I should say, having done adjunct professors and grading and whatnot. So ended up working for companies like IBM's and a few others. And since 2000, started Softheon. So Softheon is a 20-year-old company, as we call it, an overnight success in 20 years in making. In that sense, it's a little bit of a contrarian. Company has grown organically without any outside capital and financing. And that also speaks to our little bit of a contrarian culture that we have at Softheon. Primarily, like as I said, a lot of computer scientists, data scientists, some people with degree in finance and others. We look at healthcare is really a kind of a target-rich environment for optimizations and modernization, and that is our entry point. In fact, one of our pivotal points, milestone points in Softheon's history was back in 2008. We partnered with a large SI, system integrator, and they were invited to an RFP from state of Massachusetts to build this thing called Health Insurance Exchange. Nowadays, we know it as a Omnicare. I myself and a few people at Softheon at the time, we were, I believe, about 10 or 11 people, took up on the critical part of the implementation, architectural design and whatnot. And believe it or not, we implemented Omnicare in 90 days back in 2007, 2008 timeframe.
Wow.
Of course, it's not the same exchange, the one we designed it. It was a more of a MVP approach to, what we know as a health insurance exchanges altogether too. But it did have the core elements, core assets, being that a marketplace of where supply meets the demand. As you know by now that we have literally 150 million individuals in United States in one form or another subscribe to government programs known as Medicare and Medicaid, and now we expand that to ACA marketplaces. The number piles them up: 44 million in Medicare, 79 million Medicaid, 12 million in marketplace. And if you combine 29 million people uninsured, their number is about 154 million individuals. It's nearly 1 out of 2 people in the US is in part of one of these programs. So Softheon's mission really is to make, as we call it, making healthcare affordable, accessible, and plentiful using data and technology and modern capabilities. I don't want to keep throwing that buzzwords, AI, machine learning, but we do those things in our day-to-day operations. So the company today is about close to 200 people, to be exact, maybe 180 or so. But then again, literally, since the pandemic started, we have grown about 30%. We continue to hire. And we are a rapidly growing organization, and we are truly proud and privileged to be partnering with government entities, all the way from federal government to state entities, to insurance companies, and now to the associations like AARP and a few others. So that's the background on Softheon and myself.
Very, very good. I appreciate that overview, Eugene. And I think CMS just came out yesterday, said they had a very good year with good year by comparison with the exchange enrollment, the federal exchange enrollment, and added at least another 500,000 people who had lost their own employer provided health care. Where do you see the exchanges going with those kind of numbers, and perhaps under the new administration and within the midst of this pandemic?
I think, as we all know, at least for the last 4 years, ACA kind of had a major headwind coming from the White House, the administrations, and multitude of states. Barring the political, I will say that the motivation and drivers, ACA clearly closed that gap or donut hole, however you want to describe it, in that government-sponsored healthcare access and care. Clearly had some great, I will say, opportunities to help millions of people get back into kind of a healthy status altogether too. We have seen this similar kind of a playbook going back to, again, in Massachusetts, because they have been running an state exchange since 2006, in fact. So I think ACA definitely has a great opportunity, great purpose to bringing those individuals in this transitional. Let it be a young and invincible demographic, recently graduated and looking for jobs, and now they're over 26, they have to come off their parents' plans and whatnot or young couples starting a business, they need something along the line that, they need to be able to afford insurance for themselves, for their young families or their loved ones, or early retirees, 50 plus, giving the rapid pivot and transformation towards a gig economy. Individuals are deciding that, maybe it's time for me to start up my own business. So clearly, I believe early estimates were about 40 plus million individuals qualified. Of that, 12 million already enrolled into ACA. The number, as you know, was slightly higher. I believe the number more like 14, 15 million in early years. But with the headwinds, unfortunately, the shortening the open enrollment period, as you know, from 4 months to 45 days, previous to Obama administration, the Trump administration shortened the open enrollment to 45 days. And then of course, mountain of lawsuits about the different provisions of ACA, let it be individual mandate or helping the insurance companies bearing the cost of providing insurance for someone never had one. Ultimately, we did expect excessive utilization of healthcare services, which created an additional burden for the insurance carriers. And as you know, that commonly known as a cost share reduction, which is a reinsurance program, was deemed initially something that is not part of ACA, but later on was challenged by the Supreme Court, and those payers, unfortunately, many of them were forced to go out of business. So fast forward to today, I think ACA plays a pivotal role. As we all know, healthcare is one of our most precious commodity that we have. Our bodies are the most important thing on day to day, what we do, how we function. Unfortunately, healthcare has been on a rampage of excessive growth, if you will. I believe the latest number now, we're up to $3.6 trillion. Just within last year, healthcare expense went up by 5%, far exceeds the inflationary or CPI indexes. So cost of healthcare continues to go up, and ACA, I think, provides a sensible opportunity for those individuals who are in that transitional cycle in their life, whatever that might be. So I think going forward, we see an ACA under the Biden administration, that headwind now becomes a tailwind. I believe the Secretary-elect Yellen already has indicated that part of the Department of Treasury's, the plan to revitalize the economy is going to be through healthcare. We are, again, these are just merely predictions, and most of them our own predictions. We believe that we are going to see increase in subsidies as a direct correlation to declining income. Most, 20-some million people unemployed. As a condition of that, I will say we will see a Fed reacting in a fashion that they will be providing additional subsidies. Now, whether those subsidies will be directly correlated to the healthcare expenditures or will be some other form of subsidies, could be something like an HSA distributions and whatnot as well. We are also expecting and projecting that the eligibility criteria will be increased to beyond 400% federal poverty level, FPL levels. Now, we don't know what that number is going to be, 500 or 600% FPL, but clearly the population addressable market size for ACA population may far exceed that initial, we talked about 40 plus million to maybe 50, 60 million, depending upon how aggressive the Biden administration will be as it relates to promoting ACA at the same time, stimulating the economy at the same time, bending the cost curve and other reasons.
Yes. Okay. Very good, Eugene. And I think they're already talking. The Biden administration is already talking about certain vehicles for expanding the eligibility and expanding those the economic health for people who want to go into the exchanges through some of the consolidation bills or maybe even some of the COVID relief bills. Thank you. When we come back, we're going to continue our discussion with Eugene Sayan. I'd like to talk to him a little bit about consumer-driven healthcare and how that relates to, as he mentioned, 154 million people now that are in government programs. But for now, let's take a quick break and hear from our producer, Michael McNutt.
WEDI invites all healthcare IT professionals to register for our first major educational offering of 2021, the Quest for Health Equity, February 23rd and 24th on Zoom. Thought leaders in the fields of health IT and public health convened for a 2-day forum addressing the value and importance of data interoperability in eliminating health disparities in the country. For our keynote presentations, we're excited to welcome two of the nation's most influential healthcare leaders and health equity advocates, Dr. Georges Benjamin, Executive Director of the American Public Health Association, and George Halverson, Chair and CEO of the Institute for Intergroup Understanding. This meaningful and valuable event features speakers from CMS, Siren, The Gravity Project, Harvard Medical School, AHA, and more. Review our full agenda and register at wedi.org. Enter the code PODCAST to receive 20% off your registration fee. Sign up today for the Quest for Health Equity, February 23rd and 24th.
We're back, and we're talking with Eugene Sayan, founder and CEO of Softheon, on another episode of the Collective Voice of Health IT, a WEDI podcast. So, Eugene, we left off, and you were talking about the exchanges and how many, like you said, almost 1 in 2 individuals in the United States are under government programs for their health care. How does that relate to consumer-driven healthcare? And while we're on that topic, how has the pandemic affected consumer-driven healthcare? And what I'm thinking is that maybe there's a little tension between if the government is taking out over 1 out of every 2 or subsidizes or has some part in 1 out of every 2 individuals' health care benefits, does that decrease the possibility for consumer choice and consumer access? And then maybe how is the pandemic playing into that? I think I just asked you about a dozen questions all at once. I'll let you go.
All right, I'll do my best. I'll go in some order of fashion.
Okay.
So really going back to early days of 2008, as I mentioned, working with Massachusetts and working with 11, 12 carrier in early days of creating this kind of a more of a farmer's market analogy that I'm going to use altogether. It was truly an eye-opening experience for us. We saw the need for, obviously, a demand. We just talked about it, 150 million individuals. Right now, the ACA shopping experience is very limited to, obviously, there's certain programs, ACA Marketplace altogether too, but we are also seeing an early signs of kind of a decision-making, empowerment shopping experience for, as we know, Medicare, MA product, especially Advantage product and MedSups, and Part D for over 65. And we are also seeing parts of kind of consumer empowerments even within the Medicaid programs. And one notable example will be the Healthy Indiana program. In fact, program was designed and built by Seema Verma. That is our current, as you know, CMS administration under back then Governor Pence, whereby Indiana, in fact, one of the very few states have taken the early 1332 waiver of ACA rather than building a state marketplace for that 133 to 400% FPL population. They wanted to design a shopping experience and more of a consumer empowerment experience for the entire Medicaid population. So Healthy in the Indiana program today, in fact, serves, if I'm not mistaken, a little over maybe a higher, around 500,000 individuals in Indiana, whereby they receive their health benefits through some form of almost an HSA cards and what we call it a power cards. And they can go and shop and spend that money. And there are some incentives that actually the members can use to carry over portion of the unused those funds, if you will. So if you step back, for us, really the early days of ACA, when it was implemented, we wanted to do something a little different than many of the health payers or healthcare players in the ACA market to do, which was to do, we wanted to create a marketplace, truly a marketplace where the insurers can come in and they can just, quote unquote, we call it, stack up our shelves with their product and services. As the consumer starts coming in, they can pick and choose those products. And unfortunately, most of the industry went towards that, creating their own shopping experiences. So the best analogy that I can give it to you is if you are looking to buy an airplane ticket, if you will, you can go to your favorite airline, most likely the one that gives you the most mileage, perhaps frequent flyers. In my case, was Delta. Well, that was the last time I think flown about 2 years ago. It's been like it feels like a century ago. You can go to delta.com or you can go to expedia.com. If your focus is in price and comparison, you will go to the multi-carrier exchanges like ACA. But if your focus is the VIP and using those points, you'll go to delta.com. But Delta is fully aware. In fact, if you were to go ask the Delta, CEO, how many websites that you can buy a Delta airline tickets, if you will, I think his answer is going to be, I don't know. It could be hundreds. It could be, if I'm not mistaken, literally thousands of websites. The process happens in healthcare industry is through this basically a consortium called TAO, OTA, Open Travel Agency. 20 years ago, basically every airline, every major hotels come together. They created this interchange of data between all the parties so that the shopping experience for consumer has basically gone from chasing and going through, remember those travel agencies and whatnot, or phone sites or whatever it is. You can now go to one site and you can compare all the product and services. Similar kind of, obviously, the consumerization taking place in every part of our lives. Amazon has done that very well on the e-commerce side. We don't have to go to malls anymore. Our living rooms are the malls. We can now pick and shop anything that we want. Same thing happening in banking, same thing happening in other parts of the organization, our lives. I think from that perspective, that was our approach to the consumerization in healthcare. So obviously we had to do a lot more work in that sense, because the systems that we had to design have to be open to anyone and everyone who wants to participate. Through the process, we have helped numerous health plans to be able to quickly, put their products on the shelves rather than building their own retail stores, quote unquote. And also on the consumer side, they have the ability to now come to one side and they can just basically shop and compare so many different products and services from so many different healthcare payers. So that's our definition of consumerization and healthcare. How does it relate to the pandemic? Well, to be frank with you, I think that pandemic just simply accelerated that transformation, which was already slowly happening even before ACA. As you probably recall, private exchanges was the topic or the word of the town, where we felt that every employer will be asking or creating their own kind of the multi-carrier exchanges for their employers. And kind of ACA pushed that concept to the side, and everything had to be done because it was a mandate. Everybody had to do something with it. Well, COVID is another form of a mandate, the way we see it. What COVID did it basically accelerated the paradigm shift from brick and mortar healthcare to a new era where the healthcare, specifically the telehealth component, is delivered near real time, if not in real time. And here's the twist. It could be delivered by known or unknown partners or healthcare providers. Your doctor no longer is a couple of miles down away from your house or where you live. It could be in any part of the country in current status altogether too. So all of a sudden now we have this paradigm shift that you don't even know who your partners are. You are building real-time partnerships with organizations like Tela that helps you find that aggregator. It's another way of how Uber aggregates and then the cars available, nearby you in case you ever need a ride. I think that we're going into the world where the services that are being delivered to you in near real time or just in time. And just as Delta CEO doesn't know how many outlets are selling their tickets, I think we are moving rapidly into the area is that the healthcare payers, in this case, will be partnering with known or unknown partners for delivering services, not just by traditional hospital or healthcare systems, but we are seeing a plethora of companies that are funded by venture capital and private equities, and they all want to have this piece of that $3.4 trillion basket. That's what we call it, a healthcare spending. And to be frank, as you can see in the current pandemic, healthcare IT companies and public companies had the highest return in 2020 on an average of 89% gain in their stock performance. So there is definitely a big push towards the digitalization of these products and services because market has exploded in an unpredictable and a surprising way due to the COVID.
I love how you describe the Affordable Care Act as really a mechanism that was for the good of the consumer. I love that the analogy you're using with Amazon and the rest, with the idea of a marketplace being one place where you can shop, and then that idea, the second idea that the pandemic has showed us, right, is that you don't have to shop at the store next door. With telehealth, it's again like Amazon. You might be ordering something from China. For all you know, or it could be Indiana, or it could be right around the corner. So you've got the cost comparison, and then you've got the access. And what's interesting is the new transparency rules are now doing the second part of that cost comparison, right? So if the ACA and the exchanges in the marketplace was getting to see how plans and getting to shop with plans and what their various cost of health plans would be, now with these transparency rules and the transparency provisions in the No Surprises Act, we're going to get the other half, where you actually get to shop among hospitals, and as you're saying, maybe even shop among teledocs, and some of those teledocs might be in completely different states. So let's go on to the transparency rules. What is your view on that with regard to consumer health care? And maybe let's talk a little bit about where we are with the transparency rules and if we're actually going to see them get implemented this year by the hospitals and next year by the plans. And again, I asked you about a dozen questions, but I'll let you go.
Not at all. We welcome that opportunity. Again, I think that kind of in a way we are feeding off each other. So this is what happens when you bring like-minded people. We are all kind of believe in the same mission. To be frank with you, I don't think that I answer your first question about the Softheon's culture. You know, starting with myself, we talk about being a contrarian company, organically grown to the point that we have been rated as one of the fastest growing company by Deloitte nationally, by Crane in New York. And so company has achieved some great success because we feel very passionate about making healthcare affordable, accessible, and plentiful. And here's the insider for you, by the way. That accessibility, affordability, and plentifulness is the definition of a commodity per Webster dictionary. So our goal is to actually, of course, we did not want to say we want to make healthcare a commodity, right? That kind of little bit kind of throws you off your guard a little bit. But affordability and accessibility is really the paramount, we believe, in bending the cost curve, because the healthcare expense is growing in a record pace, 3.4, soon to be $4 trillion on a $20 trillion budget. So we're talking about 20% of our GDP is being spent on healthcare. And here's the sad part about it. Despite all the money that's been spent, and I'm afraid to say that the spending will continue to grow, not in direct correlation to the outcome. As you know, the fee-for-services model and basically shift to value-based and outcome-based models, if you will, been the topic for at least several years, and to the best of my knowledge, it's very difficult. It's how do you achieve those goals? How do you measure outcome? How do you measure value in the absence of a data? And the interoperability is the primary means of collecting that data and then measuring the data and then acting and putting as a feedback in a typical AI machine learning model. You take the input, you look at the output, and you try to predict what's inside the box. And using those analogies, using that sample data, and you try to apply it to the much larger data sets and so on and so forth. I think the COVID paradigm shift, if you will, it will enable companies to start gathering a lot more data. And this is where I think the interoperabilities play a critical role. Unfortunately, I think the interoperability will continue to take a little bit of a backseat, given the economic condition that we are in, and giving the spending, healthcare spending that is needed to basically control this pandemic, get the pandemic under control. So I think we're going to continue to see spending increases, not in direct correlation to the outcome. And interoperability, I think slowly and gradually will become a primary means to getting that data availability in the hands of a consumer. And great example, by the way, we talk about travel industry. This is one of the things that we do at Softheon. We like to look at everything from a first principle thinking. As you probably know, that Elon Musk is really, really popular. He talks about every day how he approaches and new problems. So we like that. We pretty much Softheon culture, with quite a few of them, with the exception of myself and a few others, we skew the numbers at Softheon because our average engineer, our average employee at Softheon is probably in their 26 and 27 years old age group, with 80% of our staff 30 and younger. And that is the kind of, that's how we look at the problems. That's how they look at the problems. So when we were on this journey to build the next healthcare consumerism platform, We just simply went back to the drawing board to say, okay, let's look at the examples. Let's see what other industries have executed on this transformation. And one notable one actually was no different than what we do today, which we're very accustomed to, ATMs. You can go to any convenience store, right? You can put your card, identify yourself, and you have access to your bank account in any part of the world for the most part. I travel to Europe quite often. I have a real-time access to my bank accounts here in New York. How does it happen? How does this process happen? Because my bank, Bank of America, doesn't know the ATM that is located at a convenience store in somewhere in Hamburg. How does that process happen? So this is the kind of curiosity that put us on a track to create the platform that we created. So just to talk a little bit about Softheon on that piece, with the exception of physical buildings, we built our own data center. We acquired our own hardware, our own software, our own compliance, because today we're working with, we are one of those unique organizations have achieved the CMS's enhanced direct enrollment status. What TurboTax and H&R Block 2 IRS is, Softheon is that entity to CMS. We have direct connection to the IRS and Department of Homeland Security and whatnot too. So within the context of interoperability, we have to comply and meet with specifications like NIST 800, FISMA, MARS-E, and so on and so forth, so that we wanted to build the foundation that is strong, will allow us to continue to expand and grow. Some point in time, as we all know, as you know, in Europe, there are a series of data protection rules, also known as GDPR. We already know that California Consumer Privacy Act actually took effect in January 2020, and it will be increasing demand. So switching back to the CMS interoperability, we think that there is going to be an opportunity. It's going to be a slower adoption. We think that given the current economic conditions, administration probably will relax some of those mandates. They will continue to push off as they have done. As a result of the COVID, some of the deadlines were already being delayed and postponed 6 months to a year. We think that could continue to happen. We think some of the penalties associated with not meeting the interoperability mandates probably will be waived or even forgiven for some time, or if nothing else, minimized. But interoperability is going to be a key element to it. The only concern that we have at Softheon is going to be not to repeat some of the mistakes that we did during the early days of kind of meaningful use. Remember EMR and EHRs and everything else, where not that many hospitals and doctors in U.S. did not have an electronic means of gathering the medical records. And then there was a movement took happen at a record pace. Now that I think probably high 90s about the medical records. But the problem through that process, we ended up, no disrespect to, we ended up creating these large silos called Epic and Cerner. Now the information is locked up. I think the interoperability hopefully will allow and unshackle that data so that organizations like Softheon can create the conduit, can create the aggregators, where the consumer can come in, they can collect all their data about their health and wellness, and then using some smart engines like Amazon's shopping decision support, Softheon has a similar type of decision support, propensity models about the behaviors and whatnot. So using machine learning, using gamification of healthcare, we think that we are able to provide access to affordable healthcare. Could be provided, like you said it, a doctor down the road, or it could be a doctor in other part of the country in the same fashion as will be done, if not better, using the technology.
I appreciate now what you said at the beginning of the show, that you said Softheon was an overnight success to over 20 years. Is that how you put it?
That is one of our exactly inside humors. Let's put it this way.
That's exactly right. But now it seems like you're perfectly placed with the interoperability rules coming through, and with certainly the exchanges having some having some air beneath their wings, perhaps at this point.
Yeah.
Under the new administration, it sounds like you're well placed. One of something that stuck out at me, and then you said that affordability, accessibility, and plentiful where I think your three terms that are part of your mission. Affordable and accessible, those sound like terms we hear all the day in healthcare policies. Plentiful, that's a new term, and it sounds very, it sounds almost organic and almost sacred. What do you mean by plentiful?
Well, I think the plentiful is, like we said, we always heard that healthcare was local. Healthcare was local at the state level. It was local at the county level. In fact, if you look at it, how even health insurance plans are being actuarially designed and priced is at the county level. Because it's targeted for the population in that given area. The networks, the contracts are designed to be extremely localized fashion. We believe with the advent of technology, with the advent of telehealth, with the advent of internet and other means of capabilities, interoperability tools, now we have the ability to have your doctors, your MRI technicians, or your specialists to be in other part of the country, and that's what happened already. Has been happening through, again, telehealth. It's happening through pharmacy companies that are being popping up, and let it be from, again, I don't want to just plug the names up there too. The consumerization is now seeping through every corner of healthcare. Mm-hmm. So basically, our definition of plentiful is that there are more places now the consumer can go to go get those services, shop around those services. So the key thing is going to be, again, like you said, having access to the price information. That's the part that it's still a little bit of a pushback. Let it be how American Medical Association is actually, designing the product around ICD codes and whatnot too. I think that's going to be some time still consumer to truly understand and compare the prices between the product and services as they're comparing prices, let's say on pharmacy between the brand and generic drugs. I think as we go towards the next generation through ACA, we believe one of the greatest things that ACA has done was able to compare product A to product B without all the confusing jargons, the HMOs and PPOs and max out of pocket and so on and so forth. ACA, healthcare.gov, Softheon, our subsidiary, direct-to-business consumer, these organizations have now simple, easy to use, a 63-year-old person may not be totally up to date with technology, to 22-year-old person can go and can compare the prices. So we believe the plentifulness will come from truly the increasing the sources of these products and services that are being delivered to the consumer, and consumers are being empowered by these new players, and they are going to come in. As I just said it earlier, I think healthcare is one of the fastest growing, the investment category for venture capitals, private equities, or public companies that are already being listed. So that's what we mean by plentifulness.
Very, very good. Affordable, accessible, and plentiful. Well, this has been a great discussion, Eugene. Any closing words? Any aspirational thoughts about where healthcare will be in another 5 years, 10 years?
We think that, again, we are perpetually optimists at Softheon, to be frank with you, because there is so much, as you know, day-to-day living. There's so much negativity and cynicism altogether, too. We believe, giving the information, giving the opportunity, healthcare is neither a right nor a privilege. We believe it's both. We all have access to or right to a healthcare. Doesn't mean free healthcare, because there's nothing free in life. Somebody had enough paying for it. I think the key point is going to be about affordability. And then the privilege portion really is that individual having the opportunity to make those sound decisions based on the information that's been provided. We did this, everything. We did this, buying a car, buying a house. We are not offended by, someone is basically giving us a low FICO scores. If that's the case, guess what do? We find a way to improve our FICO scores so we can get a lower interest rates. So I think that's the kind of, I cannot say that I am in agreement with some of my colleagues. They continue to march upon saying, well, this is too complicated, so we are not going to trust the individuals to make a decision about what kind of healthcare do they need, what kind of service do they need, what kind of, we talk about, briefly touch upon social determinants of health, right? Your zip code now is important as your blood pressure. I think the individuals has an opportunity and right to be involved and engaged with the healthcare. Until that engagement happens, until that people are deciding behind closed doors about the, what the cost of a particular procedure should be, and then try to find a way to capitate these expenses and continue to make decisions on behalf of the consumer. I think, in our view, that's one of the things that holding back to true transformation. And here's the really kicker part. The interoperability, internet, the concepts that we talk about, GDPRs and accessibility to healthcare, up until very recently, the healthcare system in the U.S. has been touted as one of the unique healthcare systems in the world. And therefore, it's not being transferable. Well, with this process, with this kind of disruption that we're now looking to bring upon the industry, making it affordable, accessible, and plentiful, so we think that people in India, China, Africa, Europe, those people will be needing an affordable, accessible, and plentiful healthcare? Of course they do. So our plea to the industry, companies like ourselves and others, I think we have to look upon interoperability, as a partnership. Interoperability is an oxymoron if you are only going to go after monopolies and duopolies in an industry, which has been the case. And to be frank with you, M&As through the M&As, right, where the number of suppliers are shrinking because there's less and less companies now that are able to. So I think that there is an I'm going to say it, how should I say it? There is something brewing very big, in our view, that will allow this platform, this technology, this work that we put in place in the U.S. actually could be easily transferable, not to 154 million transferable addressable market size. We talk about total addressable market size of US, 40 million, to 6 billion, maybe even 7 billion. So this is the exciting part about when I talk to my colleagues in private equities and VCs, they don't view the transformation, they don't view the disruption of US only. I think there's an opportunity to think a lot bigger than just US and do a lot better just than U.S. population is concerned. So that will be the hopeful thinking and optimistic thinking on our part. Then again, that we're not always right, but we'll see what happens.
No, that is a great place to end, Eugene, and that's you got me on board. We export our music, we export our science, we export so many things that America is a leader in, and if we've got this great healthcare system, let's make it better and let's export it. I think that's a great, or if not export it, serve as an example. I think it's a great end. Eugene, a pleasure having you on the show today.
Likewise.
Okay, we have been talking to Eugene Sayan, founder and CEO of Softheon. One of WEDI's primary functions is to keep health plans, hospitals, and other providers educated on health IT, and we very much appreciate Eugene Sayan helping WEDI do that today. This has been the Collective Voice of Health IT, a WEDI podcast where the health information technology community connects, collaborates, and creates solutions for a better health system for the United States and maybe for the world. Find this episode and many more on our website, wedi.org. Thank you all for joining us, and be safe.